My first forensic case was Ted Kaczynski, the Unabomber. And Ted had delusions about the airline industry and university professors. And he felt that his life was threatened. He felt that society was threatened in a way that was psychotic.
Welcome to the Most Days Show. The mission of Most Days is to measurably increase quality of life globally by helping people change their behavior. This show is devoted to understanding how change happens. Today, we speak with Dr. Xavier Amador about schizophrenia. Dr. Amador is a visiting professor of psychology at the State University of New York, and he was professor of psychiatry and clinical psychology at Columbia University and director of psychology at the New York State Psychiatric Institute. He served as co-chair of the Schizophrenia and Psychotic Disorders section of the DSM-IV-TR. He is also currently founder of the LEAP Institute, which helps families create relationships that lead to treatment, even when the person who is suffering does not believe that he or she is ill. It's an evidence-based communication program that turns adversaries into partners. He's a wonderful guest. I hope you enjoy. Dr. Xavier Amador, welcome to the show.
Thank you. Happy to be here.
I'm glad we made it. We've started a little bit late, and when you joined, you had just been stung by a wasp. So I feel
stung by a wasp.
You're really pushing through. So we're gonna talk. I want to talk about schizophrenia today, and so I feel you're a perfect guest for that topic. But before we dive in to the topic itself, give us a sense of your background.
Well, I'm a clinical psychologist. Worked for nearly 20 years at Columbia University. I'm in New York City, now at the University of Utah. And I was a research scientist and a clinician. So I've done a lot of research and published papers in scientific journals. And I grew up, really it was in my early 20s, with a brother who I was very close to, who developed schizophrenia. So that launched a lot of interest when I started my career in understanding that illness.
What is schizophrenia? Let's just start with the basics. How do we define it?
Well, it gets used all the time. Like politics are very schizophrenic, whether it's not split personality. This is a neurodevelopmental disorder. What does that mean? That means that you start off without any abnormalities, but later in life, like with Alzheimer's, you develop memory problems. With schizophrenia, you develop perceptual problems. You hear things, see things that aren't there. You also can develop delusions. And there's really a constellation of other symptoms that are common in schizophrenia. Long story short, the brain, as it matures, starts to develop dysfunction. And it really impacts on somebody's ability to stay in the same reality that the rest of us are in.
How is it different? So split personality disorder would be a separate diagnosis in the DSM, and that is not schizophrenia. Like, what is the distinction between those two things?
Well, that's split personality is dissociative identity disorder, DID, exceedingly rare, very, very rare. In fact, in my 35 years in the field of psychiatry and psychology, I've encountered it only twice. Schizophrenia affects 1% of the population. So we're talking 3 million Americans with schizophrenia. Very different disorder, apples and oranges.
But there have been some recent, at least there's some TikTok trends of people believing they've got split personality. Is that's something else? I mean, the rarity, you're talking about, it seems to appear more online. Like, what's your sense of what's happening, the trend online? People at least claiming that they've got some multiple personalities.
They're watching too many movies. Honestly, it is an exceedingly rare disorder, and 0.001% of the population, and it's associated with trauma, and we don't know anything about its neurological underpinnings. What leads to this? It seems to be more of a environmentally induced, trauma-induced disorder. It's not schizophrenia. It's apples and oranges.
And then is schizophrenia a spectrum disorder? I'm guessing it's not, but as you know better than I do, something like anxiety or depression, we all experience those things. And then when we experience too much of them, or they're having too great of an impact on our life, there's some line we draw in the sand that says, okay, now this is a disorder and we want to think about treating it. does schizophrenia fall into that category, or is it truly a disorder across the board where it doesn't serve you at all? There's no normal amount of, the symptoms associated with schizophrenia.
It's a very sophisticated question you're asking, which I didn't expect. Nothing personal, but we all have things that are similar to hallucinations. Did you ever hear somebody call your voice and you turn around and there's nobody there that you know? That's a false perception. With schizophrenia, you hear voices talking to you, conversing, giving you commands, all kinds of, you can hear my voice right now. Well, if you had schizophrenia and the auditory hallucinations, you'd hear my voice just like we're all hearing it. So it is categorically different. Well, here's another example. Do you ever get anxious and maybe even a little paranoid about what somebody thinks about you? Right. Well, with schizophrenia, that little bit of anxiety, paranoia, if you have a paranoid, constellation of symptoms, turns into full-blown certainty that the CIA is surveilling me, that, Brent is trying to kill me, and he's part of that conspiracy that's trying to kill me. And so it's a fixed false belief. So it is on a continuum because we're talking about people and human beings, and we all get afraid. We all have these little minor false perceptions. But when it's schizophrenia, it's just, magnitude of order more severe, those kinds of experiences, and they become symptoms.
And how do we think about genetic versus environmental? I mean, I find myself always, when talking about these disorders, to first think about what was the genetic advantage of it, and are we looking at a mismatch between modern environment and basically the world for which all of our our genes were built for, or is this something that's truly just much more disordered? How do you think about genetic versus environmental?
I think about it first and foremost as a brain difference. And in our field, in psychiatry and psychology, we develop these categories that are categories of pathology. But if you step back philosophically, even anthropologically, we're talking about a brain difference. And it's a brain difference that leads to all kinds of problems for the persons, all kinds of difficulty in functioning. Are there genetic and environmental contributors to getting this brain difference? Yes. So all kinds of things, like exposure to virus in your second trimester of gestation in utero, head injuries as a child, family history, the genetic component, also increases your risk. It's not Mendelian transmission. That means 50% chance that you'll get it if one parent has it. But there's clearly in many patients genetic contribution, and in others environmental contributions like the ones I just described.
And then something like, I don't know, paranoia seems like it might be a genetic advantage for survival. If I'm constantly worried about what's happening around me, I'm probably more likely to survive and to procreate. But something like delusion or, some extreme delusion makes it less likely that I procreate. And so is there a sense of where this might come from genetically, from a genetic advantage perspective?
Well, yeah, from an evolutionary perspective, we are built to have an alarm system in our brain, typically centered around the amygdala. And it's a, fight or flight response. So it is adaptive on a phylogenetic scale. It's adaptive to become fearful, to see threat. Where it becomes maladaptive is when you see threat when it's not there. And that's schizophrenia.
Okay. And then you're talking about the onset is a typically a little bit later. So when do we tend to see the onset? What does that look like? What is the ramp period? Like, where do we go from, no schizophrenia, everything's fine, to schizophrenia causing a lot of dysfunction?
Late teens, early to mid 20s. And there is a sex difference. So men tend to get it in their late teens, early 20s. Women tend to get the onset in their mid 20s. We don't know why that's the case. There's all kinds of theories about it. We do know that stress can trigger the onset of the first full-blown episode of the disorder. We also know that marijuana use, we tend to think of marijuana as a very benign drug, but if you have a biological vulnerability to this neurodevelopmental disorder, schizophrenia, and you smoke a lot of weed or take a lot of weed, marijuana, you are much more likely to develop the disorder. So late teens, early to mid 20s, I caution the families I work with and patients to stay clear.
And more likely to develop it, meaning we see a causal relationship between marijuana and basically the triggering of the schizophrenia, or it comes out a little earlier than it might have otherwise, but it would have come out, in a parallel universe where there's no marijuana.
The scenario actually is if somebody who has a genetic or biological vulnerability to schizophrenia, I may have it. I had a brother with schizophrenia, so my chances are 6 times higher than the average person, but I didn't develop it. I didn't smoke a lot of marijuana. I didn't have traumas. My brother had trauma and smoked a lot of marijuana. So it doesn't make the onset earlier, but it does reveal the illness or trigger the onset of the illness in people who have a vulnerability to it already.
But there's some set of people walking around in the world who have a genetic predisposition to schizophrenia, and in one universe, they never ingest or smoke any marijuana, and they never know that they have this genetic predisposition to schizophrenia. It doesn't impact their life at all. It never manifests. And then in this world, they did smoke marijuana, and it does present and it does cause the dysfunction. So there is a causal relationship there.
Exactly. Yes, absolutely.
And similar for psychedelics, right? I mean, there's definitely some concern about psychedelic use for small groups of people. And I think schizophrenia, bipolar would be in that category as well.
Yes. But, millions of people use marijuana and psychedelics and never develop schizophrenia. So that really important piece to remember is there has to be some biological or genetic vulnerability. In utero insult to the developing brain, head injuries early in life. Those are some of the biggest risk factors, environmental risk factors.
Yeah, marijuana does not cause schizophrenia, but if you have some precursors, it can contribute to the onset.
One of the ways to think about it is if you've got a lowered immune system and you go out and get in a cold rainstorm, you're much more likely than somebody with a solid immune system to develop a cold. Same thing.
And so is schizophrenia episodic like a bipolar would be, where you've got manic episodes that last for some period of time, those die down, depressive episodes, or some amount of time where you're in neither? I mean, how is it similar to that?
Like I said, schizophrenia is a neurodevelopmental disorder. So Alzheimer's, you have good days, your memory's okay, and then you have bad days, etc. Schizophrenia is no different. You have good days and bad days. Episodes in schizophrenia, though, where you have full-blown so-called psychotic symptoms, say hallucinations, delusions, thought disorder, the person who rambles and is circumstantial and hard to understand. Those symptoms, the episodes that those symptoms constitute can last years without treatment, without medication. It's really one of the fundamental components of good treatment. There's other things as well.
They can last years without interruption.
Yeah. Oh, yeah.
How do we diagnose it? At what point does the diagnosis happen? Is it a similar diagnosis? It's like to a bipolar. I'm assuming this is not just a multiple choice, and what's your score? There's a clinician involved, but how's it diagnosed?
By very thorough psychiatric interview. And it's the same way we diagnose anxiety disorders, clinical depression, bipolar disorder, PTSD. Clinical interview. And every now and then I do a lot of forensic work, and I get on the stand and the other side will say, well, doctor, the prosecutor will say, doctor, how can you diagnose this? There's been no brain scans. Well, brain scans have absolutely no value in diagnosing schizophrenia. It's a clinical interview. You look at the person's adolescence, early adulthood, and look for changes in their functioning.
And how do we think about comorbidity? I mean, what percentage of the time are we looking at this saying, okay, we've got schizophrenia and it's sitting alongside a number of other disorders?
Well, that's another great question. It really is. Very common comorbid conditions are PTSD and anxiety disorders and depression, affecting up to 33% of people with schizophrenia. Drug abuse is also higher than the so-called normal population. the non-schizophrenia population. And that the way we understand that, when I say we, I'm talking about the scientific and clinical community, is that it's just sort of an attempt at natural remedies. It's self-medication, trying to feel better.
So it's actually a reaction to the schizophrenia. There's a self-medicating, hey, this doesn't feel good, this doesn't feel right, I'm going to go try to solve this on my own, and then you're kind of piling addiction on top of it. But the underlying intent is actually good. You're saying, hey, I want to alleviate this suffering some way, but you end up piling on something that's actually bad.
Exactly right. Exactly right.
And then how do maybe we start, I want to switch to treatment. Maybe we start on the medication side. I mean, are there medications we really like for the treatment of schizophrenia? If so, how do they work? How effective are they?
It's a lot of choices. I mean, over 20 antipsychotic medications, and they work on different neurotransmitter systems. The main ones have worked on the dopamine system, but others are working on other neurotransmitter systems like GABA and even serotonin. But what the effect is experientially is if I have delusions, they could be grandiose delusions, not just paranoid delusions, that I'm, the vice president of the United States, not Kamala Harris. It's actually me. I could have that grandiose delusion. The medications can help to eliminate those delusions. Or if you're hearing things, seeing things, even feeling things that aren't real. I mean, we talked earlier about me getting, stung by a wasp. If I had schizophrenia, I might have the delusion and the hallucination, because I have pain, that I got stung by a wasp, but it never really happened. Medication brings the person back to what I call consensual reality. Like, hey, there's no mark there. It didn't really happen to you. In layman's terms, medication kind of brings you back to earth.
Okay. And this is a more personal question. When I was a very rebellious teen, my parents got divorced and I rebelled. And I was diagnosed with bipolar. And I'm not bipolar. I don't judge anybody who is. That I was just an angsty teen. And this was in the late 90s. And I was prescribed Seroquel to sleep. I was prescribed what I understand to be an antipsychotic. I really hate Seroquel to this day because I still struggle to sleep. And I don't think I would if I hadn't been put on the Seroquel. And I took the Seroquel for a long time to sleep. And so what is an antipsychotic like Seroquel? How's it working in the brain, and how and why is it helpful for psychosis?
Well, it's affecting the neurotransmitters that are implicated in the production of these false perceptions, these hallucinations, or these false beliefs, these delusions. Seroquel is a particularly sedating medication, so I'm not surprised to hear that you got prescribed that for sleep. If they thought you had bipolar disorder, maybe they thought you had some manic symptoms and maybe even some delusions, then it has, two things that it's supposed to help you with, right? One is sleep and the other are those other symptoms. But the good news is for people who would benefit from these medications is there's a lot of different medications to choose from, over 20. So that, and many of which aren't sedating. So there are choices.
And then how do we treat it therapeutically outside of, the medications?
Several things. There's cognitive behavioral therapy for psychosis that helps people to sort of sort out what's delusion, what's not, to manage the hallucinations if they're having them. There's psychosocial supports. There's social skills training. Because one of the things that happens with schizophrenia is you also have what are called negative symptoms. A loss of an ability to feel things that were pleasurable before, a loss of motivation, a loss of kind of interpersonal abilities or skills. And so social skills training helps the person who's suffering from schizophrenia to become more adept at looking at your facial expressions. If I have schizophrenia, and not all patients, but many, I can't read it. I'm having a hard time reading it. So that kind of rehabilitation teaches the person skills to begin to compensate for those deficits.
And how do you think about if we were to give, more or less credit for the therapeutic intervention or the medications for somebody doing well and functioning? How much of it is the kind of the pill that I'm swallowing versus the doing the work therapeutically?
Well, if somebody's doing well and functioning, I wouldn't recommend medications.
I'm saying if they're suffering from schizophrenia and then they they reduce that suffering through proactive management, medication, and therapy.
It's a wonderful option. In terms of the research, about 25% of people do not respond to the antipsychotic medication. So you are left with the psychotherapeutic and the psychosocial rehabilitation interventions. So, talk therapy, skills training. I have to do my math really quick, but for hundreds of thousands of people in our country, in the U.S., medication isn't relevant because they haven't responded to it. But for the majority of people, about 80% do respond to one or more of the medications. And by response, I mean lowering of those symptoms we've been talking about, the psychotic symptoms, hallucinations, delusions, thought disorder.
And I think you're not going to like this word, but I'll use it because I think it helps me clearly ask the question, how curable is it?
I like the word a lot. I'd like to see a cure, and I think we will eventually find one. Right now, there's no cure for schizophrenia. So, it's like a lot of brain disorders. It's like a lot of medical conditions. There's no cure for diabetes. You learn to manage it.
If I'm in let's just say, so I'm moving through my life normally, and then as a male, I hit my late teens, and I have onset of schizophrenia. And, you as a clinician see me and you do all of the, you do the diagnostic analysis, and we say, hey, Brent's got schizophrenia and it's pretty bad. It's an 8 out of 10 or whatever, to use some kind of crude scale. What is the hope in me getting that suffering from the schizophrenia down to a 1 out of 10? I know 0, cure, not possible. But how much hope is there if I take the right meds, I do the work of getting it down to a 1 or a 2?
Tremendous hope. One of the factors, one criteria in the criteria for schizophrenia is a lot of disability in terms of being able to work, go to school, develop close relationships. So, that's part of how we measure severity. It's not just the hallucinations and delusions. It's also the person's ability to engage in relationships, work, school, etc. So if those things are coming together and doing well, 60% recover. Do really well with the treatments that we were talking about earlier.
And recover meaning lead some kind of normal life, hold a job, be in relationship, be a good partner, have kids, like those kind of things, like live a normal life.
Yeah. And the other way I define recovery is having not only the ability to function in those spheres that you just described, but also be engaged in meaningful activity. Because when you're in a psychotic episode, you could be locked up alone in your back bedroom, searching the internet for proof that the aliens have put a transmitter in your brain. And that's not a life. You're not working. You're not engaging. You don't have relationships. So, you use the word normal. I kind of think of it more as meaningful and productive life is what we're aiming for.
And then what do we see when we look at maybe common misperceptions? I happen to be here in San Francisco today, and, San Francisco's obviously got a mental health crisis. There's a homeless crisis here. And I think there's often a perception of, many people suffering from homelessness, or, there's schizophrenia as one of the many things that are going on. Is that a misperception? Or when you're walking down the street of one of some major American city and you're seeing somebody behave a certain way, you'd be able to call that out? Like, talk about the relationship between homelessness and schizophrenia.
Well, I'll start by talking about a symptom. The most common symptom in schizophrenia it's a tongue twister. It's called anosognosia. Anosognosia means the person cognitively doesn't understand they have an illness. And so they burn bridges, they refuse help, and oftentimes end up on the streets. So we do have way too many people with untreated schizophrenia on our streets, homeless. And it adds to the stereotype of if you're a guy, a heavily bearded, poor grooming and hygiene, yelling at the voices person. But this is someone who has anosognosia, someone who understandably from their perspective refuses treatment because from their perspective, nothing's wrong. The only problem I have is everybody telling me I'm crazy, and I know I'm not. So that person understandably runs from treatment, but then they end up not recovering. So they're not working. They become homeless. And then once on the street, there's a lot more stress from living homeless. That exacerbates symptoms. Like any brain disorder, stress will worsen symptoms. If you have Parkinson's and you have abnormal movements, you have a stressful day, your movements are doing this. Same thing with schizophrenia. Instead of abnormal involuntary movements of the arm, you have abnormal involuntary perceptions and beliefs.
How much do we think about violent behavior from people who have untreated schizophrenia?
Let me be really clear. People with schizophrenia are no more violent than the general population, with the exception, when not in treatment, there is a higher risk of violence, unfortunately.
And that is simply just the, I can imagine if I am concerned that somebody's going to hurt me, I am more likely to defend myself or hurt that person first. Now, if that concern comes from a place of delusion, then I have acted out violently against somebody who's totally innocent and, had nothing to do with whatever is happening in my head. Is that typically is that a good example of how it would manifest itself untreated?
That's often how it works. My first forensic case was Ted Kaczynski, the Unabomber. And Ted had delusions about the airline industry and university professors. And he felt that his life was threatened. He felt that society was threatened in a way that was psychotic. And so he targeted, that's why he was called the Unabomber, right? The universities and airlines. It's just random, really, when you think about it, but it's not random to him. He felt in danger, in mortal danger, and so he struck out.
So Unabomber is from universities and airlines. I thought it was because he was solo. It was uni, the prefix, because it's one guy alone in a cabin in Montana, I believe, doing the bombing. That's not actually what it was.
No, it's university and airlines, bomber.
And then how do you separate the delusions of grandeur that we might see in bipolar and in manic episodes? How are they different from the delusion? Are there delusions of grandeur in schizophrenia? Or if so, how are they different?
So delusions of grandeur, which clinicians call grandiose delusions, are the same in bipolar disorder and schizophrenia. What's different are the symptoms, the constellation of symptoms that surround those grandiose delusions. So if you have bipolar disorder, maybe you're talking a mile a minute and you can't interrupt the person because they're talking so fast, or you're not sleeping, you have super high level of energy, maybe you're spending all your money, or you're hypersexual. There's a group of symptoms that surround the grandiose delusion in bipolar disorder that are typically different in schizophrenia. In schizophrenia, you see an inability to work, not having energy, hallucinations are common as well. So the delusions themselves, identical really, and for all intents and purposes. But the syndrome is different. The symptoms that surround that delusion are different.
So it sounds like it doesn't come with all the good stuff from a manic episode in bipolar. People will talk about being more creative, being more productive, and all of those things. Those things they're limited to bipolar, and we don't see those in schizophrenia.
That's correct. Yeah.
And then what are we excited about from a prevention perspective and taking the 1% down to 0.5% or 0.25%? How do we think about the science of prevention here?
There's a lot of research in the last 20 years that gives me tremendous amount of hope. So, and that research is focused on kids who are at risk. So they have genetic risk, or they have some of the other environmental risks I talked about. And you split them into two groups, a control group, experimental group, and you give the experimental group low dose of antipsychotic medications. And we're finding that it lowers the risk of developing the schizophrenia. I have I have a son who I adopted when he was 11 years old who developed schizophrenia. At 11, early onset, very unusual. I had him on medication for the next 10 years. He's off medication, doesn't need it, has no symptoms. So that's just a very personal, example of early prevention, changing his life completely.
And how do you think about the flip side? Now it's personal to me in terms of, I'm really, and I'm not saying you did anything wrong in this case, or that there's not, I'm not being critical at all. Well, but for my experience, I really want to go back and find that psychiatrist who put me on that Seroquel and just like, kind of give him a shake.
Yeah. Yeah.
And because I've struggled with sleep since, and I blame that, and maybe unfairly, but how do you think about medication for kids, particularly these stronger medications like antipsychotics, and avoiding the situations where kids are on medications they don't need?
My own values as a clinician is to be very, very cautious. Kids are moving targets. I'm not talking about they're running around and playing soccer. Their brains are moving targets. They're developing every day. I mean, your frontal lobes don't develop until you're 25 years old completely. So you want to be really cautious with pharmacotherapy, with medications. I've seen medications. I just told you the story of my son, change his life for the better. I approached it very cautiously and very low doses. And in terms of your sleep problem, if I could, you had a sleep problem before the Seroquel, right?
No, not really. I mean, no, I did not have a sleep problem before the Seroquel. I think I was acting out in a way that was pretty extreme, to be fair. And I was put on Depakote, a mood stabilizer, and Seroquel. And then I really enjoyed being knocked out by the Seroquel. And then in college, I would have a few drinks and take the Seroquel. And so that would even like totally turn the lights off even more. And it turned into a long cycle of basically needing medication to sleep. But I didn't grow up as somebody who was concerned about my sleep.
Well, it sounds like it really contributed to your sleep problems. And that's unfortunate because there are other choices that could have been tried.
And then maybe thematically, did we see you lived through this period as did I. Was there a lot more kind of like throw medication at it in the late 90s? Like, are we seeing that start to come down? We've seen obviously the Oxycontins and like the issues with opiates. I think we've way overprescribed benzodiazepines. There's this Seroquel. Like, does it feel like we were a little trigger happy in the 90s and in the early 2000s, and we're sobering up a little bit?
Yeah. And I'll give you some historical context. The National Institute of Mental Health had a major congressional influx of funding in the 1990s, and it was referred to as the decade of the brain. So there was a lot of interest, a lot of government funding for studies of what? Brain interventions. What kind? Pharmacotherapy. So that's part of what I think you may have gotten caught up in. Since then, there's been a huge movement of people like yourself and myself. I've suffered from clinical depression, been in treatment, cognitive therapy, medication, both. There's been a shift back to the middle of the road, rather than just it's all brain and medicine to, there's a lot more we can do that doesn't involve any kind of medical intervention. And we're somewhere in the middle now. A lot of it had to do with what happened with the NIMH in the 1990s.
So a bunch of money and focus. I think everybody's looking for the silver bullet. I mean, my own concern, we've talked about, we had an amazing expert on the podcast talking about Wegovy and all of the new, basically the diabetes interventions that are being used for weight loss. The science is really cool and it's clear, and these are kind of quote unquote miracle drugs. But, I come from this place of like, wait a minute, sometimes we just got to do the hard work, and there are always byproducts and side effects of these things. And, hopefully these are an actual miracle drug, but that tends not to be the way that it works. So it does feel, maybe to me from the outside looking in, I'm not a clinician, that on the brain side, the anxiety meds, the antidepressants, that we're finding this middle ground, as you say, and things are kind of evening out. But right at that point, we're introducing a whole new class of drugs and kind of promising, hey, you don't need the behavior and the lifestyle and the habit changes. Just, stick this needle in your belly and it's going to be all good.
And what's frustrating for me, and maybe we have a little bit of shared frustration, is that the research, the double-blind, placebo-controlled, gold standard research shows that in the case of anxiety disorders, in the case of depression and And now more and more with schizophrenia, psychotherapies can be as effective as pharmacotherapy. So more and more, I hope we move to the middle. We're still leaning a little bit towards pharmacotherapy. I support pharmacotherapy 100%, but it's not for everybody. And there are other tools that we have that the science shows have really positive impact. So we need to be wise and have a broader palette as clinicians and look at different options.
Yeah, and I understand the lean towards the medications because it's so much simpler to swallow a pill than it is to do some of the hard work. I mean, as you were describing the non-pharmacological therapeutic interventions for schizophrenia, I find myself thinking, wow, that might be really hard for somebody who's deep in schizophrenia to do that, to do the skills learning and to apply those skills in their life. That's going to be more difficult than taking a pill. And we even see with adherence to medications, even that piece is hard.
To really benefit from psychotherapy for schizophrenia, you have to be cognitively able to focus. And so oftentimes with patients that I've had, I'll say, why don't we do the medication for a few months and you do the psychotherapy? And then we can see if we can wean you off the medication. And sometimes we can, sometimes we can't. But the medication can help the person focus because there's also cognitive deficits that we don't talk about enough. So in addition to hallucinations and delusions in schizophrenia, we also see what are called working memory difficulties and focus and concentration difficulties. So to ask someone who's hallucinating, delusional, and has working memory problems to do psychotherapy is absurd. So you need the medication to sort of make the ground fertile for the psychotherapy. And then you can start looking at reducing the medication.
Maybe I've already asked this question, but I find myself wanting to ask it again. And being in San Francisco, I think brings this top of mind to me. So the person that I would see on the street who seems very delusional, seems very schizophrenic, and seems very extremely so, we feel like, hey, if we were able to treat that person in the way that we know works, like we've kind of got to solve for everybody, or we can bring this down to a manageable level for everybody, no matter how extreme it seems on the outside.
Look, I think this is a really important philosophical debate that we have, which is when someone's, for example, homeless and acutely psychotic and they're refusing treatment and they start to endanger their welfare, because of just extreme disability, not feeding themselves, etc. And sometimes as a society, we step in and we'll force treatment, but it can only last for a very short time and then the person has the choice. But in many instances, once treated, the person says, you know what, I don't want to live on the street. Let me try something different. Let me accept some treatment. So it's a very, it's the balance between civil liberties and compassionate care. Would we let somebody with Alzheimer's wander around on the street? We wouldn't. We would pick them up and put them into a safe environment. So I don't know if that's answering your question, but you got me thinking about that particular quandary.
It wasn't the question I was asking, but I think it maybe is the more interesting answer, because the question I was asking was more like assuming that person wanted treatment, but somebody going from a really extreme place to a better place. And I think you're saying yes, but the issue maybe in that case with the person you're describing is they don't want treatment. They're not seeking treatment.
Wow.
And so if we want to solve the ill here, which in this case, when it's in a public space, I feel bad for the person and I feel bad for, the business owner or whatever. Like it's not good for anybody. It's not a good situation for anybody. Now, do we take people against their will and treat them? That's a much trickier problem. And it seems a lot of that stems back to, at some point we had like state funded mental health institutions, and we stopped that funding 40 or 50 years ago. And so now the option is like kind of exist as is or go to jail. And jail is obviously not the best option. I mean, is that the gap that we see here?
Oh yeah. I mean, there's a direct correlation between the number of We had over 500,000 psychiatric beds in our country in the 70s and 80s. By the 90s, we had about 70,000 beds, and our population of mentally ill people in our jails and prisons jumped by 500,000. There's a real shift, and it's a big problem. I have an institute, the LEAP Institute, LEAP Institute. We train judges, we train police officers, we train attorneys to help them divert people from the criminal justice system into mental health treatment. I mean, we also train people like myself and you, lay people, to how to engage people in treatment. Because the most common symptom, the biggest problem, is this anosognosia, this unawareness of illness that leads to the problem you talked about earlier, noncompliance with treatment, refusal of treatment. So there are ways to engage people in treatment, and that's what we teach.
But if we could wave a magic wand in some perfect world, we have the option of something that is not jail for people who are suffering from these very acute mental health disorders, where they can go get treated in a way that's state or federal funded. We sort through the thorny issues of, look, some people are so acute that they might need, just like the example with Alzheimer's, we wouldn't want to let them wander around. We're not going to let them wander around in that state. But we're going to bring them to a place where they can actually get help as opposed to get worse. I mean, is that on the clinical side? Is there consensus on that? Would be a great answer. There's a whole bunch of political issues that get in the way.
I love that answer. I love the idea a lot, but we don't have consensus on that. There's grossly underutilized mechanism called respite beds, where people aren't going to a hospital. They're coming, hey, come and hang out at our house. And it's state funded. It's usually county funded, the ones that I'm familiar with. And the person has a chance to engage with the staff and meet other people who've just gotten off the street. And hey, do you want to try this medication? Do you want to talk with a therapist? So it's not a hospitalization. It's a step between homelessness and hospitalization. It's a respite bed. It's a house or an apartment.
And are those overutilized and there's not capacity, or we just don't have a good funnel into them?
Yeah, no, they're overutilized by the people who need them. Yeah. And there's just too few of them. That's a very, very uncommon. It was much more common in the 80s. And I don't have an answer for why. I guess I could get cynical about it in terms of where the money gets targeted. That kind of intervention, that kind of safety net is far less available than it used to be, and it's very minimally available today.
And so in looking forward, what are you excited about? Is there research happening now that we don't yet have the findings of, but we feel really optimistic about? I mean, what's coming down the pipe?
There are some new antipsychotic medications that operate on completely different neurotransmitter systems that seem to help with not just the psychotic symptoms, but also those symptoms that affect memory, those symptoms that affect the ability to engage socially. So I'm excited about that pipeline. I'm very excited about what's happening in psychotherapy for schizophrenia, cognitive behavioral therapy for psychosis. More and more work has been done in the last 20 years. It's changing lives, and it has a lot of efficacy. That's what I'm most excited about, Brent, is that more and more for clinicians, there's an emphasis on a more holistic approach, not just the medications that was the primary approach in the 1990s. So I think things are it's not just moving to the middle, it's moving more holistically.
Yeah. And I think this has been the impetus for my own focus on this. And I think it is for a bunch of people is, I spent a long time really, really struggling with my habits, the things I do or don't do most days. Is why we call the company Most Days. And as I've figured out systems for myself to do the right things most days, to eat the right things, to get the right sleep, to not drink or to not do things that I know don't serve me, my life's just gotten a lot better. And this is particularly true for physical health. It's less true for mental health, although it's still true to some degree. Our healthcare system is not really set up to help us with the most days things. It's very reactive. Come in, when you're suffering from something, we're going to help you fix a thing. And then we all tend to be on our own for these things that really matter, for doing the right things and not doing the wrong things most days. And so we've all been kind of experimenting on ourselves, and now we get to share that information. And, now that we don't have to be totally alone.
That's great that you're doing that, because, a lot of treatment is Band-Aid oriented. We're going to fix you up. We're going to quote stabilize you, then send you back out. And there's no continuity of care. There's no engagement. It's too compartmentalized. You go to a hospital, you go to a crisis clinic, you go to a psychotherapist alone. It's too compartmentalized. So I love the name of your company. That's great. Yeah.
Thank you. So any final thoughts before I let you go?
Yeah. If you believe you're experiencing schizophrenia, if you're a family member, if you're a friend, get help. There's a lot of hope. People do get better. I've seen way more people get better than not in my career. So there's a lot of hope. Connect, get educated, watch podcasts like this,
And where should we go?
Well, you definitely can go to our website, leapinstitute.org, and you will learn about a very psychological, communication-based program to help people, accept the idea that they might benefit from treatments, not just medication. That's the LEAP approach, LEAP approach. So leapinstitute.org. You can go there. Wow, there's so many great podcasts today that there never used to be. I still recommend NAMI, National Alliance on Mental Illness, .org. They're moving, the pendulum is swinging back towards the middle. It was very medication oriented. So, sort through the NAMI website, but there's a lot of good information there. So those are two websites that I would recommend. And, on TikTok, there's this wonderful woman whose name I'm blocking who has schizophrenia, and she still has some symptoms, and she is fantastic. And she normalizes it and gives you hope that you can lead a meaningful life, even if you still have symptoms, because about 30% of people don't get that symptom reduction. So they're still hearing voices, they're still getting scared or a little bit grandiose. So TikTok's a cool place to learn stuff, believe it or not. Just be discerning about it,
Well, Dr. Xavier Amador, thank you so much for your time, and thank you so much for your work.
Thank you for what you guys are doing. I'm really glad you're out there.
The Most Days show is recorded in San Francisco, California this time, sometimes Boulder, Colorado, produced by Patrick Adino, music by Patrick Lee, and hosted by yours truly, Brent Franson, founder and CEO of Most Days.